Hi, everyone. My name is Ben Abramoff. I'm going to be talking a little bit about how rehabilitation can be used to help patients who have long COVID. These are my disclosures. I do some research and get funding for long COVID related studies, as well as some advising on long COVID issues. So I'm going to start with a basic definition of what long COVID is. I like the definition that the WHO uses. I think it's a very good way to conceptualize this condition. It's a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID. So the way to think about this is that it's not unusual in the first few weeks after a severe viral infection to continue to have some residual symptoms. It's those that continue to persist that are most consistent with long COVID. They have to be persistent. So there are many conditions that come and go, many symptoms that come and go, particularly early on. It's symptoms that last at least 2 months. And it's very important that they're not be explained by an alternative diagnosis. In many ways, long COVID is a diagnosis of exclusion, making sure that there's not a pulmonary embolism or myocarditis or any other symptom or condition that could be causing the ongoing symptoms. Some common symptoms include fatigue, shortness of breath, and cognitive dysfunction, but there have been many others described. We'll be going to a little bit more detail about this. They can be new following the acute infection or persist from that acute viral illness. I'll also add worsening of pre-existing medical conditions as another example or type of long COVID. And I think this is another important feature. The symptoms generally aren't stable. They tend to fluctuate over time or relapse with periods of improvement and periods of worsening of symptoms. How common is it? The prevalence in studies vary widely. This has a lot to do with experimental methodology. It tends to be higher in hospitalized patients than non-hospitalized patients, particularly those who are hospitalized in the ICU. Although the specific phenotypes and explanations of these ongoing symptoms in these different populations may be very different. There is some preliminary evidence that vaccination can help reduce the risk of long COVID. But when you look at overall numbers, given the higher number of patients that were never hospitalized, the majority of people who have long COVID were non-hospitalized. And the numbers that are kind of most reliant tend to be in the kind of the 10 to 30% range. The US National Center for Health Statistics a few months ago did a study, and they found that about 6% of individuals are currently reporting long COVID symptoms, and about 15% had at some point. This is a great study that came out of the Netherlands. It had over 70,000 participants, and it was prospective. It had patients before and after their COVID infection, and it included a control group. So it could look at patients and say, oh, you had fatigue before and after COVID. Well, we're not necessarily attributing that fatigue then to long COVID. And this is a non-hospitalized cohort. This study found that 12% of individuals had an increase in symptoms following COVID-19 of at least moderate severity that could be directly attributable to COVID infection. So that works out to about 1 in every 8 patients with COVID. And if you look nationally with these numbers, in the US, if you estimate about 100 million, maybe a little bit more, had a COVID infection, actually probably a lot more, then that means about 12 million people with ongoing long COVID symptoms, or at least had long COVID symptoms at one point. If it's even a tenth of that, that's still over 1 million people with long COVID. The pattern varies. Some people get worse right away and then have recovery, but just never get back to their baseline. Some patients feel better. They kind of get back to where they were, and then they try to go back to their previous activities. So they try to go back to sports or work or school, and they realize they just can't function and perform at the level they did prior to COVID. And then there's a smaller group of patients that seem to continually get worse after their COVID infection. And they say, Doc, I feel worse now than I did even when I had COVID, although that's generally a smaller percentage. And again, pretty much every organ system can be affected. I've heard pretty much every symptom that may be attributable to their COVID infection. The most common, though, tend to be kind of systemic symptoms: fatigue, weakness, loss of endurance, cognitive issues, brain fog. I'd add insomnia, very common, and then anxiety, mental health issues is another very common symptom following COVID infection and in our long COVID patients. Going back to that Boehringer study, all of these symptoms were found to be greater than control groups and greater in in long COVID patients after their infection compared to before their infection. So this includes cardiopulmonary symptoms, musculoskeletal symptoms, sensory symptoms, loss of smell and taste, tingling, and then these generalized symptoms: limb heaviness, fatigue, tiredness. It's important to note the study didn't include all symptoms, so it didn't include things like cognitive dysfunction, post-exertional malaise, dysautonomia, insomnia. So probably the number is actually even higher. What causes long COVID? Well, it's still unknown. There's lots of theories. The studies, the research that's been done to date is somewhat limited, varying quality, and little reproduced. And sometimes we're not sure what's kind of the cause and what's kind of the effect. So what's upstream and what's downstream when we think about these ongoing symptoms and the pathophysiological changes that we're seeing in the bodies of people who have long COVID. And it's possible that not everybody has the same pathophysiology. I mentioned before, people in the ICU who are critically ill may have a very different clinical picture than those who are mildly ill. And even though people are mildly ill and they have long COVID, somebody with cardiopulmonary symptoms and pain may be very different than somebody who has very neurocognitive symptoms. But some of the specific pathophysiologic mechanisms that have been described include this immune dysregulation, changes to T cells, B cell populations, autoimmunity to different receptors within the body, viral persistence, reactivation, microbiome alterations, microvascular changes, blood clotting, endothelial dysfunction, brainstem and vagal nerve dysfunction. Some really interesting earlier research looking at metabolomics, serotonin levels in people who have long COVID. So I think these are all really interesting directions. I tend to think that some of the stronger research is looking at things like the viral reactivation, the autoimmunity, the immune dysregulation, as well as the metabolomics. I think that's probably the most promising area, but certainly more research needs to be done. So now I'm going to talk a little bit about rehab and how that plays into the picture. A quick background: in March of 2020, we closed all of our outpatient clinics. We started to see patients we started to decompress the acute care hospital, taking critically ill patients who did not have COVID, and then we transitioned to taking patients who were very, very sick with COVID in the ICU, on the ventilator, on ECMO, potentially on acute rehab. And we thought, well, that was going to be who we saw. And so we were concerned that this wide population of people who are critically ill would need ongoing rehab, intensive rehab, to get stronger after their hospitalization. So in June 2020, we opened the post-COVID assessment and recovery clinic. With time, it's become more of the mild patients. In fact, about 80% of the patients we see now were mildly affected by COVID, meaning they were not hospitalized, as opposed to what we expected going in. And what was the need? Individuals who had survived their initial COVID infection were noted to have significant defects and deficits in their physical and cognitive functioning, and their quality of life was overall much worse. And they were going from provider to provider within the medical system, not feeling like they had really a home. They would be told, oh, either nothing's wrong with you or it's not a cardiac problem, go see a pulmonologist. Well, the pulmonologist would say, well, it's not a breathing problem, go see the cardiologist. And frankly, there was a lack of expertise in this challenging new condition. While certainly there's overlaps with things like ME/CFS and POTS and dysautonomia, that's one was kind of people were undereducated about those conditions to begin with, and two, where long COVID and these other conditions kind of overlapped was unclear, and to a certain extent still remains unclear. So some national societies recommended having multidisciplinary clinics, even single physical location, one-stop shop. The models that have really developed from a rehabilitation side include more of a hub and spoke model where there's a central home for the patients, and they get referrals to different providers or truly integrated clinics. Commonly involved members of the team from a physician, medical perspective include PM&R, pulmonology, cardiology, and neurology, as well as groups like physical therapy. And we did a survey, and these were the most commonly involved in long COVID clinics, the most commonly involved disciplines. About half clinics do interdisciplinary meetings. We don't do them formally, but I think when you can, they can be very helpful in addressing this complex condition. And then always thinking about partnering with the primary care providers to make sure we're providing education and communication about this complex condition. So again, this is another way of looking at the model. It's really a team model with different rehabilitation providers, from case managers to physical therapists to occupational therapists. If you're able to make a team model like this, I think it's the most effective. Our team, again, was centered in physical medicine and rehabilitation. I'm a spinal cord injury physician by background. We have experience treating patients with multi-system complex medical issues, and often without a cure for the underlying condition. As of now, there's no cure for a spinal cord injury, but we think about ways to make people function and feel better. And that's the same thing really in a lot of respects that applies to long COVID. And beyond our our physical medicine rehabilitation team, we partnered with pulmonologists, cardiologists, neurologists, and lead therapists, physical therapy and speech language pathology throughout our system to make a really integrated, developed program. And depending on, we've kind of created an algorithm, and this has changed a lot over time, but we get patients to the right specialists, the right workup, and to the right rehabilitation providers when appropriate. So what are some specifics in terms of rehabilitation? So just a caveat, there's no widely accepted prescription or evidence-based for this is how to do rehabilitation for long COVID. Instead, it's really individualized, although AAPM&R has some guidance statements, as well as National Institutes of Care Excellence from the UK and the CDC on how to treat patients from a rehabilitation perspective with long COVID. And as a part of that rehabilitation assessment, we look at kind of every organ system of the body, again, very comprehensive, but with a particular focus on the ones underlined below: ADLs, activities of daily living, independent activities of daily living, fatigue, post-exertional malaise, endurance, vocational, avocational activities, and even social history, getting back to work, getting back to school. How do we facilitate things like that? I find that standardized measures, standardized surveys can be very helpful. They can be cognitive, they can be symptoms, they can be physical measures. One, it provides some objective results, so it's not my assessment of the patient, it's in some ways their own assessment. And two, it's something that we can use to track over time. This is how you're feeling 6 months ago, this is how you're feeling now, from a very objective perspective. Again, there's no universal treatment. We're looking at the underlying pathology really remains unknown, very frustrating for patients. So we must tailor it to the specific symptoms that the patient is having. And this is often palliative, and our focus again is on quality of life, focuses on function. When there are comorbidities to address, we want to address those very early on, if not first, to make sure that we're not, these symptoms are very interconnected. So if somebody is very fatigued, you want to make sure we're addressing their sleep issues before addressing their fatigue through something like a physical therapy program. In terms of rehabilitation-based treatments for fatigue, poor endurance, we've created a post-COVID physical therapy program. It's important to note this is not graded exercise. This is an individualized program. And you really want providers who are knowledgeable, if you can find them, or discuss with your rehabilitation providers, your physical therapist, a program that's appropriate for the patient. So I'm not going to go through this example specifically, but this is an example for a patient that does not have significant dysautonomia in terms of how we slowly build the program as the patient tolerates while avoiding post-exertional malaise, which I'll talk about a little bit more in a minute. And then another concept that we use a lot is what we call the 4 Ps, which is planning, pacing, prioritizing, and positioning. So making sure that we're not going past their energy window, beyond their energy threshold, and again, leading to post-exertional malaise and issues down the road. So this can be as simple as spacing out activities over the course of the day. It can be simple as getting a closer parking space at work, working from home. All these are great energy conservation techniques. And as they get to a place that they're stable, that they're functioning, oftentimes we're able to slowly build over time. Things like activity trackers could be helpful. We often use the spoons theory, where there's a certain amount of energy that a patient has over the course of a day or a week, and we work with them to decide how do they parcel that out. Again, support returning to activities, support returning to work, whether that's parking placards, work accommodations. That can be very important. Post-exertional malaise, when thinking about rehabilitation for long COVID, is extremely important. This is trying to avoid severe exhaustion after physical, mental, or cognitive exertion, emotional exertion. It can be more than just being sleepy. It can be feeling physically ill, having more pain, things like that. It's extremely common with people with long COVID-related fatigue. And one of the key features of this is identifying triggers and trying to avoid those triggers. Long COVID-related dyspnea, again, therapy can be very helpful here, whether that's breathing exercises or pulmonary rehabilitation, which is usually reserved for those who have more objective findings of pulmonary dysfunction, or those who are in the hospital critically ill with COVID pneumonia. Beth Israel has a really nice free breathing program that patients can sign up for and do from their home, which is very helpful. Diaphragmatic breathing, learning breathing techniques with the therapist. There's devices like the breather to work on respiratory strengthening. Dysautonomia, POTS, again, very common. Dysautonomia International has a great website with lifestyle recommendations that discusses things like hydration, salt, physical therapy, recovery, and countermeasures that can be very helpful. Again, this is an example therapy program, but we won't go into too much detail. Again, it has to be customized, and it has to be specific for long COVID-related dysautonomia. Things like the Levine and CHOP protocol for some of our patients is even too intensive. And then quickly, I'm not going to go through all these in the interest of time, but many of the symptoms that some of you might not even expect, there are physical therapy programs and rehabilitation that can be helpful for, from headaches to balance and dizziness problems with vestibular therapy, for tinnitus for training therapy, for focus, vision issues, post-concussive type issues, ocular motor issues, tracking issues. Vision therapy can be very effective. It's one of the, when you can find it, you can get it covered. It's one of the most effective things we can do. For people who have more of a muscle pain, joint pain picture, aquatic therapy, maybe some aerobic exercise, as long as they don't have post-exertional malaise, can be effective. And even smell therapy exists for people who have smell disorders following COVID. A couple of the websites, absent.org, fifthsense.org, have home programs that patients can do with things in their own house. Research is limited, often observational, quasi-experimental. Again, I'm not going into the details of these studies, but just know early studies do show promise for rehabilitation, and really very few significant side effects or adverse reactions when done properly. Again, this research is still coming out and still building. So what are the overall lessons, I think, for rehab for long COVID? We may not be able to address the underlying pathophysiology. We always start by addressing comorbidities where you can. This is, I think, where rehab is very strong. We're focusing on making patients feel better, improving quality of life. The focus here is really on rehabilitation techniques, but also consider things like medications. We also consider things like lab work to identify other underlying issues at play. Manage expectations, reassurance that recovery does happen even late. We've had patients after 2 years get better. It can be slow, it's incremental changes. Sometimes I see it before the patient sees it. Beware, there's a lot of kind of misinformation out there about long COVID. Go back to the research, go back to professional guidance statements. Self-management, things people can do on their own is extremely helpful. symptoms are interconnected. So even if you don't think you can address their fatigue, often if you can address something like their pain, their fatigue will secondarily improve some. Provide continuity of care, let them know that they contact you, have scheduled follow-ups. I find that very helpful. There are a lot of health equity issues at play in long COVID. Keep them in mind. I know we didn't have time to kind of go into those today, but happy to kind of discuss with you more. And it's a lecture in and of itself. And much more research is needed in rehabilitation for long COVID, particularly the specifics. We need protocols that can be widely dispersed, that are appropriate for patients, that aren't graded exercise programs, to really help them recover. It's like you wouldn't want to give the same medication to every disease. You don't want to give the same rehab prescription to every patient that has long COVID. So I'm happy to answer questions, and thanks again for having me.